You're listening to Mastcast, an SM podcast where your hosts, Candice and Rachael, explore the complexities of living with a rare chronic disease through personal experience, patient guest stories, caregiver perspectives, insights from specialists, and updates from the research and advocacy communities, with the purpose of bringing knowledge, connection, and hope to those affected with mastocytosis and related conditions. Hey everybody, welcome back to another episode of Mastcast, an SM podcast. I'm your host, Candice.
And I'm your other host, Rachael.
And we are so excited today to have a special guest in Dr. Hussein Abbas. He is a research scientist at MD Anderson who specializes in hematologic malignancies. And so today he's going to talk to us specifically about systemic mastocytosis, as he sees patients like us, including me. And we're going to talk to him about his journey to treating people with SM and his take on research that's happening now and what's exciting and what's really great in the SM community and where he sees growth. So we'll start right off the bat. If you would like to tell us a little bit about yourself,
Sure.
generally, kind of where you come from and what brought you here.
Yeah, well, thank you for having me, Candice. Thank you for also shedding light on such an important topic. So I am, as you mentioned, I'm a physician scientist at MD Anderson. So basically, I see patients focusing on systemic mastocytosis, and another two diseases are hypereosinophilic syndromes and AML. So relatively rare diseases. And originally, I actually come from Lebanon, and I came here, did my training, did my studies, and I did a PhD, then an MD, and then I kind of merged science and medical care with the interest of trying to identify, um, why are certain patients having more symptoms than others? Why certain patients don't have any symptoms? Why do patients respond to certain therapies while others do not? So my time is split between 20 to 30% of my time seeing patients, 10 to maybe 20% of my time between clinical trials and trying to define the therapies, and around 50% I overlook a research group in my team that really asks these type of questions. Um, so your next question was about why am I doing SM? Is that
Yeah.
yeah?
Yeah. What interested you in SM?
Um, you know, I wasn't. I never thought I would like. If you asked me 5 years ago, this was not a plan, and neither did I have it. Well, I've always had a plan to be a physician since I was little, but I never thought I would be an SM physician. It really came across by organically, and it really found me more than I found it in the way that my research questions led to inflammation, and then one of the most representative disease of inflammation in my mind is SM that was really not studied at all.
Fascinating.
And that's really how we're like, okay, there's inflammation SM, but there's also no dedicated program for SM. So if you actually look at AIM website and you see there's really not much within 800-mile radius from the Anderson, and nobody really fully dedicated to clinic for SM and knowing the needs for it. It became an organic development actually over time, and also one of my patients who I was treating for AML, after we cured her AML, we found out that she had SM. In fact, one of the cards behind here are actually from her. She keeps sending me every year a box of cookies and these cards. So it kind of found me. I mean,
Wow.
like one thing after the other over time that we realized about SM and kind of built a program around it over the last couple of years.
And so you said the last couple of years. So you've been doing SM specific work for about that long?
Yeah. So now, my clinic usually is on Fridays, sometimes Wednesday, but basically almost 90% of the patients I see are only SM patients. So yes, all my time
Wow.
in the clinic now, I almost only see SM and hypereosinophilic syndromes. And HES is a very rare, so I'm going to focus on SM, but almost like tomorrow's my clinic has probably 9 SM patients. So that's pretty much what I do now. Yeah.
That's fascinating. Is that what you're
Took
going to
the
say,
words out of
Rachel?
I was going to say the exact same thing. Literally, it's fascinating. I think
Yeah.
it's really amazing to see how doctors got into this, since it's such a it's such a rare disease, and
Yeah.
most of my doctors kind of look at me confused when I tell them what I have. So it's nice to meet doctors who are like excited to be a part of researching that and learning more about it.
Rachel, to your point, and this is really, I wouldn't say it's their fault because, I went through
Sure.
residency and fellowship, and honestly, we never had formal training in SM. Like this wasn't
Hmm.
a lecture on SM. So now actually part of the Hemon Fellowship at MD Anderson, now I started giving SM lectures. Although I was part of this program here, but really when I was a fellow, we didn't have lectures here about SM. So that was not even a topic. And very few places actually. I'm not aware of places that give it. But now what we're doing, and something that over the last 2 years I've given, really every few weeks I've given one talk about SM to physicians to educate about it. And in fact, patients know more about SM than the doctors that they see, which is a very interesting. And I learn a lot from my patients because I learn a lot from you and what you've been through. And that's why, with patients that come, I always tell them, tell me your journey. Tell me how did you get to know that you have SM? And that's a question I always ask that natural, because you probably know this, but maybe for your audience to appreciate this is, it takes 7 years from the time you develop a symptom until you have a diagnosis of SM. So by the time the patient sees me or you come see me, you may have even lost trust in the medical system altogether. Like this doctor is going to
You're speaking our language.
yeah, and it's not really, and it's not your fault, and it's not the doctor's fault per se.
Right.
Just this is why I love this when you reach out to me, Candice and Rachel, about doing sometimes, because I think it's important to hear the doctor's perspective of
Hmm.
why sometimes we don't know.
Hmm.
It's really because there wasn't enough awareness about it. But now I can tell you there is more and more recognition of this. And at least I and several other colleagues are trying to do a lot of efforts and trying to push for more knowledge awareness among trainees, because you really got to start there
Hmm.
at the trainee level and then build this up in order to go. Because your first guess, if you have a SAM, you're not going to see an oncologist, right?
No.
You're going to see a dermatologist, you see an allergist. So there's this disconnect. Also, how does a dermatologist communicate with an oncologist to
Yeah.
so there's all these things. That's why now we're reaching out to dermatologists, we're reaching out to allergists. I make, a joke. I was in a meeting today that I now attend more allergy meetings than I do
Uh-huh.
meetings, which is very interesting. And I go to dermatology meetings, which is also which I never thought I would. So it's
Hmm.
also a learning curve for me from the patients to what's going on.
But obviously, it's working to some degree. So I got diagnosed in 2009, and I believe that the average diagnosis time and I'm not sure the accuracy of it, but what I was told was that it was 19 years.
Yeah.
So in the last, 16-ish years or so, it's improved by about half. So obviously, the things that the doctors are doing today, making sure that they teach more trainees and kind of get that information out to people more readily is making a big difference.
Yeah, that's exactly what I thought when he was discussing the 7 year. I thought it would be good context to know that Rachel has been diagnosed for quite a long time now.
Wow. And how are you doing, if you don't mind me asking?
I'm doing okay. I'm in some kind of a flare up, and I, for the life of me, cannot figure out why. It's been more managed since I've been on some new meds the last couple of years, but I don't know. I had COVID the end of last
Ah,
fall or whatever, and so I think that might be potentially a factor. Um, but otherwise, I'm doing okay. It took me a long time to kind of get to a point where I had my symptoms largely controlled, because they've kind of just been like run the gamut of like all the different types of ones, and trying to find all the right doctors to treat each individual symptom it's tricky. And then my local oncologist doesn't quite know, doesn't he treats more MCAS patients than he does
yeah,
systemic mastocytosis. So I try to go see other specialists once in a while to make sure that I'm keeping up with the research.
yeah,
Mm,
And
I'm still here. I'm good.
yeah.
Yes.
And she's doing amazing work for the SM community always.
yeah.
A great advocate. But since you mentioned research, one of the questions that we had for you is, what do you see as like one of the biggest advancements in research? I feel like since my diagnosis only 3 years ago, like everything seemed to happen all at once. So I'm curious,
Yeah.
to date, not future looking yet, but what's exciting to you the most? What's the biggest breakthrough?
I think we it's only, I mean, it's 4 years ago that happened, or 3 years ago, the KIT inhibitors. And now when I also think about it from the indolent and advanced form and the non, but because the indolent is the most common form, or the non-advanced, maybe we can focus a little bit on it, because I think
Mhm.
the advanced, there's still a lot more that need to happen. But in the indolent or non-advanced in general form, I think, of course, having a targeted KIT inhibitor that avapritinib is an approved drug, and recently bezuclastinib has shown really nice data in at ASH. So that these are two exciting things. Now patients have options, which if you met 19 years ago, there was no option. You're like, okay, you take 4 Benadryls, 2 Montelukas, 2 of this, 5 of this, and then okay, am I sleepy because I have a SAM, or am I sleepy because I've taken 4 Benadryls today, right? So these are the questions that start coming up. Now, no, we actually do have options where we talk about, okay, what can we back off from the other drugs and other medications so we can have better quality of life? I think the improvement seen with the approved drug and with the data shown in December from Bezu and the AVA from before, and the 4-year term follow-up, they showed data about 4-year follow-up of avapritinib, really exciting data, and showing that these are durable responses, and meaning patients who had a response initially and maintained the drug could really continue to have good responses to therapy. I think these are exciting. Is it done that? No, because you could be on the drug X or Y, and then you may benefit in some but not the other aspects. And the question is why. This is really what I'm interested in. This is really a lot of the research we now in the lab is, why did you respond, or somebody responded to X or Y symptom but not the GI, but not the brain foggings, but not all
Mhm.
that? What are the other things? Is KIT inhibition alone sufficient, or do we need to add something else? So these are the unanswered questions, but the excitement is there is an option, there is a treatment. There are risks with any treatment. There's side effects with anything. Even if you take a pill of Tylenol, there's side effects. But there's always the question of benefits and the risks. And
Mhm.
can we back off from over-the-counter polypharmacy, which I don't think anybody would like to take 5, 6, 7 medications a day, right? I don't think that's the goal. But if you can replace it with one that could help, then I think that would be very exciting. But we need to wait and see over the next few years, what else can we add, or is KIT inhibition sufficient?
Well, I was curious about since you mentioned other, like, maybe targeted therapies, is it Bruton kinase inhibitor? If that's showing, I know that there are some available, or one available anyway, and if that's showing any promise as like a dual therapy with KIT inhibition, if you still have like reactions, even
Yeah,
if you're on an inhibitor.
the data, I can't speak for the data because it's not public yet, so we'll have to wait. It's an interesting trial. We have it open here, so we have patients, we consider, and etc. But I can't speak for efficacy. The data is not out yet.
Yeah, that's fair enough. What research are you excited about coming down the pipe? Sorry, Rachel, you're about to jump in.
Sorry, I was
I'm
the
just
same
talking.
thing. Go for it.
Research. I think we need to think of research in SM I come from an AML background, so in AML, acute myeloid leukemia, there's a lot more research going on. I
Mm,
think in SM, the amount of research that's being conducted, the fact that there's not much happening is exciting, because now it's an opportunity to discover and learn and do all of this. What
mhm.
I'm excited about when it comes to SM, or I would like to see more of, is the treatment of patients with advanced SM as well, meaning patients that don't have the indolent, but their platelets are not high enough to receive KIT inhibitors. For instance, for
Oh,
anyone
sure.
to
Yeah.
receive avapritinib, or the way bezuclastinib trial was written, platelets should be above 50,000, etc. But what if somebody has low platelets? What do you do for these patients? And they have symptoms, right? This is seriously an unmet need area, and this is something we're working on. The other area is biomarkers. Like we do have if any patient participates in the study of SM, they know they have to fill these questions. It's every day, it's every week, etc. It can be cumbersome, and these could fluctuate. The question then becomes, can we find objective, non-subjective markers that one could trace? Like, when you do your blood test, you look at the white count, right? Your white count should be within this range, right? And that tells us normal or not normal. but really, can we find similar biomarkers in the blood that could really tell us about the symptom burden that distinguish life, from having headache because, you were staying up late last night, or versus headaches because this is SM flaring up. So these are things that will require some time, will require really a lot of, because it's a rare disease, you can't work, like we can't work just as a single center. We can't work just at MD Anderson doing all of this. We really need to bring all the research community together to try to build on this. And I think this is where biomarkers, better therapies for the advanced patients, and really understanding why certain patients are responding to therapy, other patients are not, and learn from that, and to help the next patient, to help the patient after. But this will take some time and will take really a village to make it happen.
I love the idea of biomarkers that will tell me if I feel crappy today because of this thing or that thing, so I can stop
Yeah.
gaslighting myself into thinking that, like, well, maybe it was the weather, or maybe it was this
Yeah.
thing, or maybe it was like the fragrances I walked past yesterday, or the 27 other things I could probably come up with at any given time. So that would be, I think I probably speak for myself and a lot of other patients how useful that would be, both like clinically, but also like on a day-to-day basis as people.
I agree. And in fact, that's what really got me into SM, is really these type of questions, and using blood-based biomarkers for that. So we're trying to develop those. Again, it's a lot of effort because, to do such research, you also need funding, you need people, you need a lot of resources to make it happen. And now we're really trying to apply for grants, and explore opportunities, and trying to get awareness also within the research community beyond. Yeah, it may not be a deadly disease per se like ISM, but there's also death in living sometimes. If people are not really enjoying life, not doing well in life, that is also not good quality of life. So what
Hmm.
can we do about this? So a lot of awareness trying to be raised about this, and again, research is the key for this. The reason we advance, and really we have better control of infections, of cancers, and all of that compared to 60, 70 years ago, is because it was mandated when a lot of research was invested in it. A lot of, the federal institutions were invested in it. The community came together. So all of it really, all these need to align. And I do think there's more and more now excitement about this. So I'm hoping over the next 10 years, we'll see some of these questions being answered in an objective way, rather than just give me the score of how you feel today. And you're like, okay, but maybe I'll feel different tomorrow. But then
Mm,
I think having some objective data would be extremely helpful.
I completely agree. And that kind of leads us to our next question, because you're talking about the lives of patients and how that affects things. So after years of treating systemic mastocytosis patients, what do you think are some of your key takeaways about what it means to live with a chronic disease like systemic mastocytosis from all the patients that you've seen and treated?
I think what it means is that the symptoms are real, and I think acknowledging that what you go through as a patient is a real symptom. Uh, it's not something that is not real, is very important. So sometimes, I actually feel challenged sometimes when I know the patient is going through something, but it's not SM, because they come to be
Mm,
ruling out SM or confirming SM, and I kind of don't feel it's the SM. It doesn't mean what they're feeling is not real. It's just
mhm,
not explained by something called the SAM. And,
mhm,
and and really acknowledging that there's another entity going on is real. And same thing for the SM patients. Acknowledging that what they've been through is important. And a common thing I tell patients that I talk to them about, even if I give you pill X today and I'm telling you this is likely gonna work, what your body had gone through for 7, 8, 9 years, 7, 8 months, whatever, is not gonna be fixed within 1 or 2 months. This is gonna take years. It's gonna take months to years for you to actually feel different. And that's one. And the second thing that I do in my clinic is every patient gets a form that we fill when they first come, about the questions, and rated 0 to 10, just to get an idea how their symptoms are. And I'm always impressed when I sit with a patient who scores 10 of everything, meaning they don't feel well at all. It's like, how are you?
mhm.
I'm doing great. I was like, what do you mean? No, that's not. Oh yeah, I've been like that for 20 years. I was like, correct, but can we do better? And then that's the patient's what pause usually is like, wait a second. Yeah, I mean, that's your normal, but that's not the true normal, right? The true normal is we can do better. Now, again, there's nothing magical there that I can give to a patient and completely transform life. And now you're going to be 100%, because there's really no normal. I mean, my normal is different than his normal, than your normal, normal than their normal, whatever it is. There's always somebody's different. But I don't think anybody should live with pain. I don't think anybody should live with the idea that I can't wake up the next day, or I don't know if I'm going to wake up the next day feeling energetic. I think that's the extreme of not being normal. Even if somebody adapts to it, I don't think we should adapt to it. I think what we should do is overcome it. And to think about overcoming it, sometimes you need medication. And that is okay. It's just when I build that momentum to get to a point where the 10 becomes a 5, because a 5 may not be 0, but it may be more manageable than a 10. And these things, acknowledging these things and educating patients about these things is very important. So that I learned that it does require a lot of trust, that the patient needs to trust me, right? Because like, who's this doctor talking to me about this? What does he know about this? I'm right? I'm not living in your shoes. I don't know what you're going through. I've only been doing this for 2 years. You've been living this for 20 years. You're right. But so there's this sense of trust that you want to build with a patient, that I think it's a very holistic way, and it may take few visits. It may take a few discussions to realize that as a doctor, we're trying to provide guidance, and as a patient, I want to learn from you, because with SM there's so much variability. It's no one size fits all. There's no guidance. Like, I started my approach where I document on every patient on my like how much they take, and we do that at the medrec. But when we try to collect the research for it, we realize every patient is like the variation in how I treat, not intentionally, but the variation how we treat the doses of Benadryl, the doses of drug X, Pepsid, all of that is quite different, because what works for one patient may not work to the other. So personalization of the patient of care for patients with chronic diseases is very, very important. Is cannot be one size fits all. And that is something I'm also learning and adapting, because you want to balance those things, right? And that could be very challenging with patients who, if you are a patient and you had your own style of what you eat and what you want to eat, I'm not going to come and change it. If that works, and I always thought, if that works for you, you're happy with that, go for it. Do I think the lowering certain diets may or may not? I don't know. It may work for you, but it doesn't mean it may work for this other person. But if it makes you feel better to stop eating this or eating something else, go for it, because that's really what matters. And I think that's the most important thing, is realizing this. It cannot be one size fits all for patients with chronic diseases.
We talk about that a lot, the heterogeneity of SM. It's just every single person has a different experience of it. I mean, there can be overlap, obviously, but every person has such a different experience of it.
I can see why Candice likes seeing you so much as a doctor. It's very obvious. I said I can see why Candice likes seeing you as a doctor so much. You have a very humanized approach to it that I think that not all doctors have, and I really appreciate that.
It is really helpful. I know the first time I saw you, you mentioned getting someone's story. That was essentially exactly it. Like, how'd you get here? What's going on? What's your story?
Yeah.
And figuring that out. Obviously mine's a little weird, but that's all right.
I think they're all kind of weird. That's the interesting part about SM patients. I've never met anybody who had where it was just like a run-of-the-mill type of story, I think. We've all had some pretty strange journeys to get to where we are.
It's a journey. I mean, obviously, it is a journey. I mean, it's a big load to carry at some way. These cells have no actual weight, but I do think their impact is heavy. And I learned from patients that don't have symptoms. They're fascinating. I have a few patients in the clinic. Fortunate, they just really don't have anything, and that really impresses me. So I want to know why, right? Like, why do they not have anything? And these are important, and some others do, but they do, as you mentioned. Everybody has a path that how they ended up in my clinic, and it's always interesting to hear that path.
Yeah, I mean, that makes a lot of sense. I think, yeah, I'm always fascinated to hear that there's anybody who has SM without symptoms, and I know they exist.
Yeah, that is.
But to me, they're it's like a unicorn. Like, I'm like, it's like this mythical thing. Out of curiosity, so is there something about mast cell diseases or systemic mastocytosis in general that surprised you the most to learn in getting into this field more like as
Yeah.
your main focus?
Yeah, I think the most surprising thing to me is how come it's the same mutation that occurs KIT 816V, yet you have so much variability. And this is another main focus of the lab, where we ask, let's think of SM beyond mast cells. It's described as disease of mast cells, but I don't think it's just mast cells. I think it is beyond mast cells. And so one thing that's always surprising to me, like how is it a unigenic, like a single gene is responsible for such variability? It's impossible. There's something else going on. And even when you get rid of mast cells, the disease is still there. So that tells you it's beyond mast cells. And so one thing we take in the lab or in the clinic, when I think about patients, I think what we call a beyond a KIT or mast cell centric approach. We are always thinking beyond those cells, and that is really where we're hoping to make the most impact, and that's where you can potentially help patients that still have symptoms even when you get rid, even when the tryptase is normal, you have symptoms, right? And that for me is very important.
I love to hear that because I think about this a lot, like a lot, being that I am on a TKI and I've only added supportive meds and I've only instead of shedding them, I've taken more. So, and my tryptase has dropped very significantly. And so to know that I'm still dealing with these things,
Yeah.
I have these questions also.
I
Same.
for any patient in my clinic, I don't know. I rarely talk about tryptase. I mean, at the level I don't care what your tryptase is. You can have high or low tryptase. It doesn't matter. It's how you're feeling. Tryptase is just a number. If you're feeling great and your tryptase is 70, well, so what? What am I going to do about it? Nothing. In fact, there's a good number of patients with normal tryptase and have a lot of symptoms. So tryptase is just a number.
Yeah.
For me, it doesn't really impact my decision making and how I'm approaching. In fact, the criteria you do not need a positive tryptase to be a sample or to have a sample. It's one of them, but you don't need it to be there to have it. So these are the things where we also looked at, and others have as well, have looked at baseline characteristics compared to tryptase compared to KIT. There's no correlation, meaning you have so many symptoms and no tryptase, and the opposite is true. So that's again why it's beyond. I think it's really beyond mast cell activity. It's really beyond that.
Mm-hmm.
Yeah, I totally agree. We have so many other questions for you, but we are running up against your time. So I think I'm just going to make an executive decision here. And we wanted to talk to you about that difference between ISM and ASM and progression and all of that. But I think that's a deeper conversation that if you're up to it, we'd love to have you back to talk about.
Yeah, I'm happy to
And
talk about this.
that would be
Yeah, I
amazing.
don't mind coming in. That's fun for me.
Yeah.
Us too.
I don't like the word aggressive SM. I think it's wrong. I wish we go beyond that. I wish we stop calling it aggressive SM, because if I am a patient and you tell me I have aggressive SM, I'll be freaking out. The term itself is
aggressive.
It is. It's not good. It's a scary term, and I don't like it because let's define what does it mean. Like what is an aggressive SM and how is the criteria? So we can talk about this, because I think it's important to reach out to this 20-30% of patients with SM that don't have indolent.
Oh yeah. Oh, definitely.
Because they're also siloed a little bit. But so I'm glad you're gonna shed
Very
light.
much so.
And I'm glad you're gonna. So we can talk about that as well as separately. This is fun for me.
Yeah, I would really
that.
like to focus on that, because to your point, exactly, I think they feel ignored a little bit because they are a smaller part of the population and they're complicated in a lot of ways. And so absolutely we will do that. We'll have a whole episode on that, the spectrum of disease. But we did have a couple of audience questions, which I really wanted to get to. And I think some of them, they kind of grouped together a little bit, but there were so many about fragrances. So fragrance is so clearly a common trigger and a severe one for a lot of people. And the questions kind of ranged. Yeah, yes, Rachel included.
It's my biggest trigger too.
And I deal with it, but not to the same extent. But we have other folks who are straight up anaphylactic to synthetic scents. And so they can't be in the world. And one of those people asked, how do you go from existing in the world and being fine to like one day in anaphylaxis from a fabric softener that was never a problem before? And I think that also touches a little bit on this question of onset. You know, I've been hearing that talked about. It's like, okay, you're living kind of normally. Maybe you have some weird things, but everything's mostly fine. And then suddenly things are not fine anymore. And you have this anaphylactic event or this, you know, cascade of things. So that's two questions in one. But I would love to hear your thoughts on the fragrance sensitivity and the idea of onset.
So I'll start with that question, and then I'm going to bring up the point of anaphylaxis, because something I was literally talking about today at noon, and I think it's very important to clarify. But let me start with the fragrance question. It really goes back to, you cannot treat this disease equally across patients. And I don't know why some patients are more sensitive than others to fragrances. I don't know if we have a clear explanation. If there is, I'm not aware of, or I'm not up to date on the literature on that area. So I would love to do some more research on the olfactory sensation, and then come get back to you. I can actually review, and maybe we can address it next. But I do want to
That'd be
bring up
great.
second.
I would love that personally.
I could, honestly, I could, because that's interesting, right? That's an interesting concept, and why is there hyper, like, why is there hypersensitization to the olfactory system in patients with asthma? So that is an important question, and I don't know it for sure. But the second question about anaphylaxis, and I do want to emphasize something here. And that is not the fault of patients, CD only, and not only the fault of the physicians only, but I do think there's a general misunderstanding of what defines an anaphylactic shock. Because we tend to use this term in contexts that sometimes may not be true anaphylactic. It may feel like an anaphylaxis, but when you start digging into the details of it, I think we need to take a step back and ask, did the patient really have anaphylaxis? And this is very, very important, because it has implications to work. It does have implications if you're doing certain lines of job. It has implications for the quality of life, how you do it, when you do things, and how you want to practice life. So I think that what really should start with is defining anaphylaxis as an objective thing. Meaning when patients have anaphylaxis, did they need an EpiPen? Or what, did they feel dizzy and they were fine? Did they have a syncopal episode, meaning they passed out?
Mm-hmm.
Because a true anaphylactic event may require airway intubation, may require EpiPen, blood pressure dropping. It's multi-organs, not just one system.
Mm-hmm.
And patients, and I don't blame them if you're not sure, of course, get the EpiPen and consider it anaphylaxis. But I'm actually more curious on how many patients felt the need to inject themselves with an EpiPen.
So this is a question. Yeah, this is a question patients ask all the time. We,
Constantly.
as people, we wonder all the time: is this an epi-worthy event, or am I going to be okay? And there are people who have never used one who like take a Benadryl and are okay. I know sometimes I'll have an event where I can just pop some extra Zyrtec and I manage to recover fine and I'm okay. But I hear you, absolutely. We intend to have an expert on anaphylaxis join us one day to really talk through this, because it's complicated and it's scary. And how do you know? How do you know?
And I can help identify that expert if you want. Sorry, you want to say something?
No, that would be wonderful. I was going to say just that, just to Candice's point, that I've had this for 16 years, and there have been a handful of times where I'm like, maybe I should have used an EpiPen, but I ended up okay, and I didn't die. So maybe it was an anaphylactic shock, even though because we're told that it's usually 2 or more organs, like once there's 2 or more organ systems involved. But if it's my throat's kind of swollen a little bit, but it's not swollen shut, and I have an upset stomach and I'm flushing, well, technically that's 3, but I wouldn't use an EpiPen for that because I'm not like on death's door.
Mm-hmm.
So I could see there's a lot of ways in which the language we use to describe these things, and I always say this word wrong, that the heterogeneity.
Mm-hmm.
Thank you. Candice is the expert on saying that word. Of this disease leads to a lot of further questions about when it is appropriate to use an EpiPen or when it isn't. And I think that could be several episodes on its own, for sure.
But I think that's a very important one, because now the question is, does Zyrtec reverse anaphylaxis? The answer, and again, this is with medical disclaimer, I'm not trying to give medical
Yeah,
advice.
yeah.
Okay, but
Of course.
does cetirizine, any of those drugs, diphenhydramine, reverse anaphylaxis? They don't actually. They do
Mhm.
not reverse anaphylaxis. Could they block certain uh, progression of certain symptoms? Yes, particularly urticaria, certain type of reactions, but not a true anaphylaxis, not
Mhm.
true anaphylactic episode. But when in doubt, then in general, without here again, not trying to give medical advice, but in general, it is recommended when somebody is having or feeling they're having it, it's always better to be safe than sorry about and give it, because you don't want to get. But making more educational awareness of how to define anaphylaxis may help patients who have reactions to fragrances, food, or other things maybe better adapt, because they will feel more comfortable or more confident. Wait a second, I'm not having anaphylaxis. I'm having a reaction. I'm having
Mhm.
an allergy. But that allergic reaction is not necessarily an anaphylactic reaction. And I
Mhm.
hope if that mindset is kind of tailored in that way, then the patient may feel more comfortable, may confident in being able to be exposed to certain things that they weren't before. So that would
Mhm.
be kind of my advice in a way about, before we get to why and how, is define and raising awareness about what is an anaphylactic episode medically
Absolutely.
as, how is it different from syncope, how do we perceive it, and how should we, when do we seek help? When do we say we need to give EpiPen? And I'm sure you know by now there's the EpiPen intranasally, because some patients
Mhm.
may be
Mhm.
scared of giving it IM. Now there's an intranasal option, but it doesn't mean we should use it more liberally. It's an easier route in case patients are not comfortable giving that uh, uh,
The injection.
injection.
Mhm.
That does kind of make sense, Candice.
Mhm. Yeah, it does. I think about my one anaphylactic episode, and I did use an EpiPen. The one wasn't enough, but I also learned that I didn't do all the right things that I was supposed to. It relieved things for a moment before I I guess the rebound or secondary, whatever they call that. But my symptoms weren't standard. They weren't airways closing. So this is the part of anaphylaxis that's scary, is that like you have a vision of it in your mind, face swelling, hives everywhere, airway closing, but it doesn't always look like that.
No,
It can look
no.
like very different things. And so that's, and of course, even in ERs, they don't always recognize it if it doesn't present really normally, and they don't know what SM is. And, it gets to all these other complicating factors. But I totally agree with you. The way I distinguish it for myself, having only had it happen once, is it's about pace. Like, I'm having a reaction when I'm flushing and I'm brain foggy and my stomach's upset and I'm not feeling well, and then I take something and then I feel better. Okay, I was having a reaction to something. I the experience of anaphylaxis was pretty extreme. It happens all very fast, and it's happening faster than you can really even, well, for me, I even recognize that's what was happening. Um, yeah, it's a whole conversation that I think is,
But this is why, when in doubt, Candice, I think you should use the treatment, because you don't want to take risks. But
yeah.
importantly, to recognize the definition, because when you relay that information to your primary care physician or other doctors, so they're able to really better understand. Because again, us as physicians also, we sometimes don't always document it the way we should document it, because
Mm,
maybe allergists, I think, are better. Of course, they're the best at this, allergists, immunologists, and making sure it is really done more appropriately than so. Like even me, I had to go back to the textbooks when I start doing a sum to understand, okay, what defines an anaphylaxis?
mhm.
Because I don't want to put it in the chart and say, okay, it's an anaphylactic episode, when maybe they didn't have it, because that may also impact job, so anything. It may
Sure,
impact
sure.
their perception of the disease.
Mhm. Oh, it definitely impacts perception. My goodness, it's an emotional
Yeah,
experience.
yeah, absolutely.
Dr. Abbas, we want to be really respectful of your time.
Yes.
I know we're getting close here. Would you have time for maybe one more audience question? And if not, that is totally
Yeah, no,
okay.
let's do. I can walk immediately after this. Yeah.
She's
There
like,
was,
I can run with it.
um, you mentioned something about different specialists and how they treat it. One of our other questions from the audience was, what specialists do you think that systemic mastocytosis patients should also be seeing on a regular basis? And so I kind of
Really,
thought that
really
that
good.
lend
No, I love
itself
that question. I
right to
love
that.
that question. I think it should be tailored towards their symptoms and what's going on. If there's a bone osteoporosis issue, they should definitely see a bone specialist, whether it's endocrinologist, rheumatologist, depending who sees them. I always refer all my patients to a bone specialist here, because patients with SM are at higher risk of bone health, progression, and that's some meaning they may have osteopenia, then osteoporosis, then fractures, and that is something we need to be cognizant about. So I always refer them. Now, when it comes to dermatology, allergy, immunology, GI, and supportive care. Let me start with the allergy immunology. Lately, I've been less and less in feel the need to send patients there unless there's an overlap with MCAS, because I don't manage MCAS. I don't know how to manage MCAS. So I co-refer to co-manage patients with that. But other than that, I don't feel the need but I do have great colleagues with allergy immunology, and I always reach out to and ask them questions, and without the patient needing to go. I think centralizing care would be good if we can. Dermatology also now with the advancement of KIT inhibitors, I think we're much better at controlling it. Certain instances I still refer to derm, but really not as a must. Is more depending if we're able to control things on basis of treatment or not. GI, similarly, again, if I'm not able to control it, if I can't, okay, there's diarrhea. You don't want to forget that other things can cause diarrhea, IBS, cancer, other things could cause these problems. So unless I'm suspicious, I usually just keep patients in my clinic without referral, but it's always on my mind whether I should send them. But one physician group that I've been more and more lately realizing, wow, could be very helpful, is the supportive care team, and mainly like psychiatry, supportive care, all of that. And I'm realizing we're actually really making progress with several patients who are having difficulty coping with the disease, because in addition to hearing from me from SM perspective, they need an expert who can help them with other aspects of the disease coping mechanisms. And I'm realizing this has been really great partnership. So that actually has been my number one referral lately, more than the others, simply because I feel the other symptoms I can really manage in the clinic, but if needed, I could refer. So that kind of pretty much I don't think I forgot anybody, where I've been pretty much referring patients to or kind of discussing patients.
That's really interesting and really helpful to hear. I know that people will like to hear what their team could look like, especially if they don't have a specialist like you, which is frankly most people living with SM. Yeah. We are so grateful for your time. This has been such a great conversation, and I will hold you to coming back and having
Absolutely.
more
I
conversations
want to ask
about
you like 20 more
So many
questions.
questions.
Everything you said made me think of like 5 more things I wanted to
I'm
pick your brain
happy
about.
we can have that. No, I think this is exciting, and we can have round table. I mean, one thing, offline we can talk about round table if we want to have other, forum discussing these questions.
Yeah.
We
Love
can.
that.
I mean, these are fun. I mean, this is really important. I learned from you guys. I mean, this is very important. So if you're going through something, how you're coping, because this will give us different perspectives. So I think it's great.
And
Thank you
patients,
again.
ourselves
Yeah.
included, really appreciate
Well,
Oh,
likewise.
yeah.
you
We're-
and doctors who are willing to come talk to patients about this stuff. So thank you.
Thank you for doing this. I think this is wonderful. Truly. Thank you.
Thank you. This has been great for us too. Well, I won't speak for Rachel. It's been great for me too.
It has.
Yeah. It's allowed some deeper connection, and I think the community is really is enjoying hearing it. But you are welcome to leave. Rachel and I will probably stay on and
All
do
right,
some
Thank
wrap
you
up.
again.
But
Take care.
thank you so
Bye.
much.
Bye.
Bye-bye.
Bye. That went
Wow.
great. I want to ask him 27,000 other questions.
I know.
I started to write them down. Like, okay, so there was some diagnostic criteria that was kind of proposed a few years ago, and he said something about SM and MCAS, and I wanted to be like, okay, so answer this for me, because there's like, depending on how you read this proposed stuff, and I don't know actually what got picked up and what didn't, but like, can you have SM and MCAS?
Yeah.
Because
well, he
I think
literally
that you
kind of
can.
said that. I mean, he just
I
said
thought
that.
so, but then I've heard
Yeah,
other
he
doctors who
said,
might be
"I just-
working with an older version of what that criteria look like and kind of don't frame it that way. So I don't know if it's like it takes a certain amount of time for like new information to get disseminated to different doctors. I've heard like I think it's like 10 to 15 years for like new information that we know that's been proven to get into like the textbooks for like
Oh yeah.
people in medical
And
school.
then into like
and then kind of
setting.
spread out into the world where it really impacts us.
Which means we're always so much further behind, like in patient care than we are in therapies, like actual,
But that's where I think stuff like what we're doing here are really important, because like we can kind of go right to the source and talk about it. And I think that that's where SM patients as a whole are kind of like magical a little bit, because we know I think I learned, I mean, I was like 21 when I got diagnosed, and I realized real quickly that if I wasn't my own expert, everyone was going to tell me something different.
Yeah.
Everyone wanted to prescribe something different to me. And this is like long before they had anything that was even specific for SM. This, they're just like, well, this off-label drug might help, or how about this one might help with that thing?
Right.
And I'm like, I've got more side effects than I do symptoms now. And it kind of got to a point where I was like, okay, I'm going to have to do my own homework and figure out what actually works for me, what side effects I'm willing to tolerate, which ones I'm going to be like, I'm going to need a different option here. This doesn't work for me for X, Y, and Z. Like, which ones actually improve my quality of life and not just my symptoms, because those
Right.
things in certain cases don't align.
Right.
If I lose something important to me, but I get like 10% more functionality, it may not be worth it to me as a person, and it
Right.
might be worth it to somebody else. So, there's a lot of stuff about being an advocate that like makes it, it's like, it's a challenge, and it's also a positive at the same time. So
Absolutely. Having access and people who are willing to talk to us. I think also we're unicorns in that almost any patient, especially if they have a specialist, has access like this a little bit, because those specialists are like, I'm so interested in what's happening to you.
my partner needed a prescription refilled, and I was like, well, why don't you just call your doctor? And they were like, it's
doesn't
5
work like
o'clock on a
that.
Sunday. And I was like, oh, I think we have very different relationships. I was like, sometimes I text my
You can just,
I try not to abuse it, but like I've somehow wormed my way into most of my doctors' lives in a way that I don't think they probably wanted very much.
I hear you. I had I swear the question started from the very first thing he said about getting into SM because of inflammation.
Yes. Okay.
And I have so many questions just about inflammation and its effects on the body. I mean, obviously we know some of those things, but like how did inflammation lead you to SM? And what about inflammation do SM patients deal with more than anything? And are we especially targeting inflammation? Because I can be like so inflamed in my whole body that I'm a different size day to day, like in clothing. Like some clothes don't fit on high inflammation days. Like
I've been dealing with this lately. It was chill for a while, and then like I would say maybe late January, early February, I suddenly shot up several pounds. And like this has happened before. As far as I am aware, I have the same mediocre
nothing
eating
different.
habits.
Yeah.
I get a sporadic amount of exercise, but it's usually like a lot because I'm bad at sitting still. Like nothing really changed in how I was living my life, other than my symptoms were worse. And it doesn't. There's been points in my life where if I eat, don't eat, and like none of that's intentional. I just have a lot of ADHD, so occasionally I forget. If I do X, Y, and Z or something else, like it doesn't really have like these are the things you're told to do if you want to lose or gain weight, and it has no effect on what I do. Like no matter how much I exercise or how much I eat, it doesn't really have a direct influence on my body size. And other times where I'm not having that issue, it definitely has like a very obvious cause and effect.
So weird.
And
That's so weird.
It drives me nuts. And honestly, it's uncomfortable. Like it's not even about like my body image, which I think from a lot of people in the society we live in, like that has a big impact on your mental health because of the way we treat it societally. But also it's physically
but it doesn't feel
uncomfortable.
good. Yeah, it just doesn't feel good.
My clothes hurt.
Yeah. Yeah, absolutely. That was, I mean, truly from the very beginning. And there were so many places where he said so many things that were, well, A, we've talked about a lot. B, were brought up in the Hero Summit, which
Yes.
for those still listening to these after credit type conversation, Rachel and I do have plans to do some mini episodes about the Hero Summit, because we really think that you guys need to hear about all the things that are happening that seem to be happening behind closed doors. They're not. It's just that you convene people, but there's so much anyway. That's a side note. But acknowledging the patient experience, acknowledging that doctors are human, like the whole thing is.
I can see why you love him. He sounds like a great doctor.
I'm grateful to him. I'm grateful to him. I'm still getting to know him as my doctor, but absolutely incredibly compassionate from the beginning. And yeah, I've also
It's
had a chance to be on a panel with him, and I think I'll do that again in May. So we've gotten to know each other that way as well.
That's wonderful. I just think that's like really, it sets doctors apart when they treat patients like people and not like
Hmm.
listen, if you want to look at me as a problem to solve, I'm totally cool with it. Like, please solve my problems. I'm trying to.
Hmm.
Um,
But
but
also treat me like a
but also
person.
I'm a person and I have
Yeah.
like a whole life and other aspects and things about me. Listen, honestly, SM is probably like the least interesting thing about me.
Right. Right.
Um, and it's a really interesting thing. So like the bar is kind of, not that I'm like, okay, that sounds so self-congratulatory. I'm a really strange person,
I'm
and
the
so
coolest person.
I'm
I'm very
no,
interesting.
I'm like moonlighting as a farmer lately. I installed a fence right before this. Anyway,
No,
so
I get it.
I
I
learned
get
how
it.
to install drywall over the week. I don't know. I do a lot of weird stuff. Not to say that I'm the coolest person in the world or something, but I think
I'm not
that
cutting any of this.
I know you're not. I hope you all don't hate me after this. um, um,
No.
and there's some questions I want to ask him. And I know we had some other um audience questions that we didn't get a chance to ask just because we got
Yeah.
short on
Yeah.
time.
Yeah.
Um, but there was one that we were asked about like gynecologic health,
Yes.
and and I don't remember specifically about what the person who requested that question was referring to, because there's so many different ways to approach
Well,
that.
really, I think she was wondering, like, how would he, as an SM expert, like, coach or what would he suggest a patient do or ask their provider in a gynecological setting when they have reactions to things, or what materials could they provide? Or it was basically like, how do I communicate with my gynecologist that I'm weird and things happen to me different, and how do we overcome this, you know?
I have such a jaded response to this because I've personally asked so
Yeah.
many gynecologists this question. And I eventually got really lucky in finding a pelvic pain specialist who works for a urology clinic that, like, just by coincidence, a therapist I had at the time happened to have a different, but like in the same vein type issue herself, and
Hmm.
recommended the doctor. And I've seen her ever since. But she was telling me recently that they looked at, I think that's where I got the information, but they were looking at vulvodynia, which is unexplained nerve pain in the vulva,
Hmm.
and they expected to find like stuff about nerves in there, but what they found were mast cells. Big shock. I have so many health issues in that area. Boy, that episode will
Uh,
have a lot of oversharing about my personal life. Prepare yourselves, everybody. But you know,
yeah, hey,
it's
it's
important
necessary.
because
Yeah.
it's
It's not
hard to find
necessary.
information. No, it is though. I think it
Yeah, yeah, yeah.
humanizes it to have like
Yeah.
somebody willing to talk about it, rather than
Yes.
all feeling like we're dealing with these issues in isolation by ourselves.
Yes.
Because in a
We've
lot of
talked
ways we
about
are,
this.
but we don't have to be.
Right. We've talked about this a lot. I think so. You mentioned like feeling self-important or whatever. I kind of sometimes I think about this whole podcast thing, and I'm like, why does anybody want to hear my voice over and over and over again for an hour talking about obsessively about this one topic? Well, obviously, people who live with what we have are obsessively thinking about the topic anyway. And
We don't
I
really have a
want to use it
choice.
as a tool. I'm willing to use my voice, and I'm willing to share my experiences. And I had the experience previously of doing a podcast, so at least I had a little bit. And I thought, A, I like having conversations with people, and B, I'm willing to overshare. And
Same.
I do think to the point you were making, we do this in isolation so much, and we just don't have to. And the more people are willing to share their experiences however they do it, like whether it's something like this or writing or advocating or just telling friends and family and helping open people's mind to what it means to live with a rare disease. I think that's all really valid work. But if I can also, in this space, if we can also give voice to other people who are going through it and hear their stories and really share in those experiences, it builds community and it breaks down the stigma and it creates validation. And I just hope that people are feeling that when they hear us. Yeah.
One thing I think I've learned in the last, I don't know, probably 15 or 20 years of my life, is like every time I feel like the squeaky wheel and I'm kind of like being like the buzzkill or like whatever, the
Mhm.
person pointing out that something's inaccessible or
Poison.
that whatever, like like
Mhm.
I find that me speaking up helps somebody else, right? So
Yeah,
like
exactly.
I ended up falling into running events because I really just wanted to go to events that didn't make me sick. And then later I wanted to go to events that also took care of people in a way that was relevant to like COVID precautions. And
Mhm.
and our it turns out a lot of other people were looking for the same thing.
Yeah.
Um, that, not everybody need the fragrance-free stuff, but I've had people with asthma who get migraines, who
Yeah.
have a lot of people with MCAS. I don't know why. They tend to find me just magically and for no mast cell related reasons. Um, but all of those people have individually come up to me and been like, "Oh my God, it's so nice. Like, it's not, I don't have it as bad as you do, but it's so nice not to have to worry about it." Um,
Yeah.
like, and I just, so like, why are we doing this kind of thing? One, because we're willing to talk about ourselves and overshare and be the squeaky wheel a little bit louder, but like, also because there has never been a time that even like me venting on the internet, like
Mhm.
I vented about my brain fog on a website I used to write things on, and I had someone come to me at a conference. I think I mentioned this on one of the other episodes, and their wife came up to me and said, "Oh my God, you changed my partner's life.
Mm.
I had just been venting. I was just having a really bad week." And I wanted to describe to people how bad brain fog can be because at the time it was really
Mhm.
debilitating. And it turns out that I described some other symptoms in what I had written, and they aligned so closely with what this other person was experiencing that they were able to go to their doctor and been like, "I want to get checked out for like some kind of mast cell disease." And they turned out they had
Mhm.
MCAS, and they were able to
Yeah.
get on medicine, and it like really made it like being able to put a name to it and get a diagnosis and then figure out how to treat that diagnosis, like changed their whole life.
Yeah.
And so I hope that us talking about it is good for like helps people. I think
That's
it's unlikely it
my
wouldn't.
I know, yeah, that's my hope too. And I think that you talking about like when we get into because we will talk about the gynecological aspect of things, just like the just intimate contact can be challenging for people for lots of reasons. And so being willing and open and able to talk about that will help someone else feel less crazy, less I don't know. I don't want to say gross because it's not gross, but if they feel that way, like if it's like, because you don't have to feel that way because it's
Or
just
guilty.
bodies and or guilty. Yeah. Any number of things yeah, I think that the more people talk about it, the less alone we feel and the more we can accept even our own state, our own situation.
I mean, yeah, I mean, even I feel like you and I are really comfortable talking about this stuff, but there's like so many days that I struggle with like trying to figure out
Sure.
how to deal with this stuff and like have a lot of hard feelings or when it
Mm.
impacts stuff I really wanted to do or I'm
Hmm.
having some kind of massive reaction. I don't have enough patience for anybody because I feel like crap.
I won't
But
even
there's
tell
so
you
many
the
different ways it
story.
shows up in my life.
Yeah, I won't even get into it, but I had a complete meltdown a couple weekends ago. And that was like it was so weird because in the morning, early in the afternoon, I felt great. I was like high on life. Everything was awesome. I had spent the whole weekend in my garden, so I was like physically tired, but I felt good and like grounded and very peaceful. All those things. It was just like the perfect little concoction of things. And then by that night, I was a nightmare to be around. Like
Relatable.
it was not good. Somehow Denny is still there, but I was not kind. I was not friendly. I was not with it. I was not in control.
I somehow have two partners who want to put up with me. I don't even know how that's. I got really lucky. I don't know. Um, but I
Yeah.
I bet a lot of our listeners probably have more questions for Dr. Abbas and
Absolutely.
possibly for future episodes with other doctors. So if you do, Candice, where can they send them?
Oh man, please send your questions, your stories, your ideas, your contacts if there's someone you think we should talk to, all those things to podhost at mastcastpod.com. Um, you can also find me or the podcast on all of our socials. Um, we're there and we want to hear. I love hearing from people. I know we haven't had another patient story on yet, but that's a high priority.
We will.
Um, yes, and I think that'll be our next episode after this Dr. Abbas episode. I'm so excited to start talking to patients, and there are so many like us who are out there advocating in so many different ways, and I want to hear from them. I want to know their story, how they got where they are, and what brought them into kind of like front-facing advocacy, and I just think it's cool. And even if they're not, I don't care if I keep talking about advocacy because I think it's really important that we do that in some way, but I think that can look like so many things. It doesn't have to look like being on a panel or a webinar, or, it doesn't have to look like a podcast. But I thought this was great. I really enjoyed the
Yes.
conversation. We did a whole second podcast on the back end. Sorry, everybody. Thanks for listening to MaskCast. Your hosts are not medical professionals, and nothing discussed here should be taken as medical advice. Please speak to your medical provider about any issues you're experiencing or therapies you're interested in. If you have any questions or comments, please email us at podhost@mastcastpod.com.